Hello, I am Dr. Karen D. Goodman, a professor of music therapy at Montclair State University in Montclair, New Jersey, and welcome to my presentation on the MTA-ED Music Therapy Assessment Tool for Emotionally Disturbed Children, published initially in 1989 and then published with further explanation in 2007. The background of this assessment tool is the following. This is the first published music therapy assessment tool in child psychiatry, and the development of the tool was motivated by my 4-year grant at New York Hospital Cornell Medical Center in White Plains, New York, to work on the inpatient child psychiatric unit. I found that the stays of the children were very short, on average 3 weeks, and the conventional treatment on the unit was leading to gaps in diagnosis and intervention for the treatment team. As a result of that, I decided to formulate and develop this assessment tool. It was developed in both the inpatient and then the outpatient unit, and it was supported by the unit head psychiatrist who I conferenced with on a regular basis for feedback. What are the purpose and the aims of this tool? There are 7 that are indicated here. My initial purpose is to have an interview with the child regarding previous background in music and the use of music with family members. Then I sought to assess the developmental appropriateness of their social emotional functioning while in music, their ability to organize musical experience, and following the content of their musical behavior, as well as changes in the musical behavior over the course of sessions, and the possible meaning of these changes. The information was interpreted in consideration of their family history, presenting behavioral problems, affective developmental levels, presenting diagnosis, previous background in and associations regarding music. The investigation of their musical response was possibly linked to particular pathology. This was a goal, however, it was not achieved through the course of the 4-year grant. Target client group. The initial inpatient group included 4 girls and 14 boys, ages 3 to 15, all presenting with suicidal ideation or attempted suicide. The average stay was 3 weeks inpatient on this transitional 14-bed unit. There were 2 individual 45-minute sessions that were conducted twice a week. Additionally, 4 children were seen in long-term music therapy assessment, including 1 child who was seen for close to a year with a once-a-week 45-minute session. Diagnosis of the children included the following: organic personality syndrome, adjustment disorder, socialized aggressive disorder, dysthymic disorder, major depression, conduct disorder, atypical psychoses, attention deficit, separation anxiety, and oppositional disorder. On the outpatient unit, I assessed 3 girls and 3 boys, all who were referred for 2 45-minute music therapy sessions. Their diagnoses included conduct disorder, pervasive developmental disorder, elective mutism, and oppositional disorder. Process of assessment. What did I do? Initially, I had a verbal intake where possible regarding the interests and participation in music. Then each child chose an instrument or instruments to perform on. They either supplied or received an age-appropriate musical structure and were free to elicit verbal comment related to or not related to their playing. Musical responsiveness evaluated all aspects of the musical performance as well as the musical changes within the performance as they related to behavioral changes in the session. Nonverbal reactions and client-therapist interaction was also noted. The emphasis on musical responsiveness was either instructive or improvisatory. Other musical participation could include listening, composing, movement, songwriting, or musical drama. The descriptive information from the music therapy evaluation was compared to ongoing psychotherapeutic work with the patient as presented in case conference, log reports, referral summaries, and interviews. So just to clarify, the format for this music therapy assessment is open-ended based on the presentation of the child and their musical interests and inclinations. And so for that reason, it requires someone who is an experienced practitioner, comfortable in moving in different directions using music in therapy. I'm going to review the items that are indicated on the assessment tool. There are 6 primary areas, and within each one of those areas there are breakout items. And underneath each of these 6 areas there's room on the assessment for description of what happened in the session. So the practitioner is to take specific notes on what is happening musically. The first area is natural response choice, and that could include one or more of the following: percussive, vocal, movement, listening, instrumental, composition, no clear choice, negative choice, or natural response choice changes. The second area of the assessment, musical preference, includes the following: the child is tolerant of music as an accompaniment. Child is attracted to music as an entity in itself. Child is dependent on developmentally regressive material. Child is attracted to music apart from conventionally peer-appropriate choices. The child prefers music that is secure and predictable. The child is bored by simplicity, or the child has associations with their musical preference. The third area of the assessment is in reference to changes in musical responsiveness. These include control of rhythm, control of dynamics, control of articulation, control of tone quality, control of melodic line or phrasing, control of steadiness of pulse, the physical disposition of the instrument, and the appropriateness of the expressive quality. The fourth area of the assessment includes verbal associations, either before, during, or after the session, and including song lyrics and storytelling and musical drama. The fifth area of the assessment includes nonverbal reactions, either before, during, or after the session. And the last area of the assessment includes the client-therapist interactions, mutually responsive, selective, or oppositional. What kind of training is required in order to conduct this assessment? The experienced practitioner must be comfortable following the lead of the child in conducting music therapy with varied options for participation. DIR training is a plus. Training in developmental psychology is a plus, and there is an option to train with me. There are also case study examples in my publication in both 1989 and 2007. What is the interdisciplinary impact of this tool? When I originally developed this, I was working on in a very prestigious training hospital, New York Hospital, Cornell Medical Center, now called Columbia Presbyterian. And so every time we had grand rounds and I presented case studies from the assessment, the meetings included psychiatrists, social workers, psychologists, occupational therapists, and special education teachers. The recommendations from my intake were helpful in diagnosis and intervention for all of these players working with the child. What are the ethical considerations of the assessment? The results of the assessment intake should be shared only with team members as well as the family. If one took video footage, it would be subject to approval from an institutional review board, and publication cannot disclose the name or details that would violate the confidentiality of the client. For more global information on ethical considerations, please see the recent work of Dr. Kenneth Brucia. Here are my references, and I thank you very much for listening to this recording. If you have any questions, please feel free to contact me at goodmank@montclair.edu. Thank you very much.